Our next speaker is Professor Peter JEZZARD, Herbert Dunhill Professor of Neuroimaging at the University of Oxford. He will be talking about new developments in magnetic resonance imaging of cerebrovascular disease. Over to you, please.
Okay, well, thank you, particularly Canny, but thank you everyone for inviting me. It's been a pleasure to visit Hong Kong. So I am going to just firstly show you a few of the things that we're working on in our lab that I thought were relevant to the mission of COCHE. So firstly, we're doing quite a lot of work on arterial spin labeling methods, including quantitative perfusion imaging, and also subtraction angiography. So using ASL as a method for looking at the blood vessels, as well as looking at the delivery of blood to tissue. And we're doing this both at 3T and 7T. We also have done quite a lot of work on vessel wall imaging using a blood suppression technique that we developed called Dante, developing various protocols that use that. Some work on motion correction, which is important in perfusion imaging and also in the vessel wall imaging that we've done. We've also done quite a bit of work on high-resolution time-of-flight angiography, especially at 7 Tesla, trying to look at the very smallest vessels and the lenticular striates, getting information on those. And then finally, we've been doing some work on pulse wave velocity measurement as a way of assessing vascular stiffness. Now, I've only got time to focus on 2 of these items today, so I'm going to focus on our arterial spin labeling work and our pulse wave velocity work. So firstly, for those who are not familiar with arterial spin labeling, the idea here is that you acquire 2 acquisitions, one in which the blood water is left in an uninverted state, and so it travels from the feeding vessels into the tissue of interest, in this case the brain, and adds signal to the, see if we can move the laser pointer. There we go. It's there. I can see it, but it's, okay, it's easier to move on this screen, thank you. So in that case, the blood signal is adding to the static signal. And then you do another experiment in which you invert the feeding blood water before it arrives in the brain. And so the signal is slightly subtracted in that case. And when you take the difference between these 2 signals, you end up with an image which is weighted just towards the blood signal, the blood water that's been delivered to the tissue during the inversion delay between the labeling and the acquisition. Now, you can fit the signal at a series of different inversion delays to a kinetic model, and you can see that schematically here. And this gives information both on the blood flow and also on the arterial arrival time, both of which are clinically useful measurements to make. So this is an example of quantitative perfusion that's been calculated from that kinetic curve in units of milliliter per 100 grams of tissue per minute. Although having seen Yi's talk, I now need to use his methods to make sure that these are fully quantitative. And you can also get maps of arterial arrival time, which, as I say, is also clinically interesting information. And in these maps, you can see this is a healthy subject, but you can see evidence of the longer arrival times in the border zone regions between the major feeding territories in the brain. Now, the other thing about arterial spin labeling is that you can label specific vessels using a technique called vessel-encoded pseudocontinuous ASL. This is a technique which was described by Eric Wong at UCSD. And what you can do is you can label particular vessels. And so in this case, the inversion efficiency is high in the right vessel system, and it's in a control condition or a low labeling efficiency condition in the left vessels. So you get a contrast between labeling in just the right vessels versus the left vessels. You can do the same thing in the anterior-posterior direction. So here you can see high efficiency labeling for the anterior vessels, and then a control condition or low labeling efficiency for the posterior vessels. And by contrasting these, you can look at either the left-right or the anterior-posterior, or indeed at some oblique angle. So here you can see oblique labeling. Here are examples of perfusion images that have been collected in different ways. So this is in the top row, labeling all vessels versus none, and then you can see labeling left circulation versus right circulation, anterior versus posterior circulation, and then this is an oblique view. And by solving the sort of matrix of different acquisitions, you can show maps of the originating feeding vessel for different locations. So in green here is the tissue that's been fed from the left internal carotid. In red is the right internal carotid. And then you can see in blue and magenta, this is the right and left vertebral arteries. So this is a clinical example of using this kind of technique. This is a patient who was imaged about an hour and a half after they'd had a stroke. You can see evidence of hypoperfusion in the right MCA territory. You can also see some evidence of collateral flow that's occurring in more posterior regions. So these are regions which would normally be fed by the left middle cerebral. They're actually being fed from the right middle cerebral artery territory, or at least the left interior carotid artery. And you can see that by 27 hours, perfusion has been restored in this area of hypoperfusion, but it wasn't fast enough to avoid an infarction in the flare image, as you can see on the 28-day follow-up. But interestingly, in that region of, oops, can I go back one slide? Just take me back one, thank you. There we go. You can use that for backwards, okay. As you can see in this region that had the collateral flow, that the fact that there has been collateral flow, there we go, we've actually spared that territory and it has not suffered from an infarct. You can also take the vessel-encoded pseudocontinuous ASL preparation and add it to an angiographic readout. So this is the same type of vessel-encoded, so the same kind of vessel-encoded preparation, but this time with an angiographic readout. And you can look at different phases as the blood has spread through the feeding arteries. So here's an example of a healthy volunteer showing the arrival of the blood and passing through the major vessels. And interestingly, in this particular individual, you can see, for example, the left vertebral artery is actually feeding the right posterior cerebral artery in this image here. So it looks like for this particular individual, as the blood passes through the basilar artery, it actually maintains its coherence but flips around and feeds the contralateral and posterior artery. You can also apply a kinetic model to this type of data. So if we model the bolus itself, the pseudocontinuous ASL bolus, as a top hat function, we then need to convolve it with some kind of dispersion function, which is shown in the bottom here, which has a time to peak and also a sharpness associated with it. We need to apply some T1 relaxation as well. And so this is the signal model that we expect to see in the data that we actually acquire. And as you can see, you only actually see the sort of trailing portion of this curve, and that's what you need to fit to. And from that, you can extract various parameters like the blood arrival time, the time to peak, and also scaling factor A, which is actually proportional to the blood volume per unit time, which is passing through the vessel. So here's an example from a patient. This is a patient who's got an occluded left vertebral artery. And if we look at the contribution of flow in the posterior cerebral arteries, we can see that the right posterior cerebral is being fed more or less as expected from the right circulation, so from the right vertebral artery, and in red from the right internal carotid. But on the left side, the left posterior cerebral is receiving most of its flow actually from the right vertebral artery and a little bit from the left internal carotid, and obviously nothing from the left vertebral artery. Now, one of the things that we've realized is that when we conduct our angiography experiment, we're doing our labeling and then immediately following it with the imaging portion. For the perfusion, we're doing the same labeling and leaving a post-labeling delay before we have a readout to give us our perfusion images. And we wondered if it would be possible to combine these two things into a single experiment, where we would, from a single label, be able to get both the angiographic information and the perfusion information from the same data. And this is some experiments that Tom Ockel in the lab has run, in which he's done exactly that. So he's used a series of radial spokes that have been performed in a golden ratio manner. And from taking a smaller number of high temporal resolution spokes and using undersampling theory, compressed sensing theory, you can extract a series of angiograms at different phases following the labeling. Whereas if you take a larger number of spokes and reconstruct at a lower resolution, then you can reconstruct perfusion images. This is an example for such a data set, which is the same underlying acquisition has been used to reconstruct both angiographic information and perfusion information at various different labeling delays. Tom's also worked on optimizing this. So if you use optimized variable flip angles for the readout train, then you can improve both the angiographic information and the perfusion information and allow the signal to persist for longer as it passes through the vascular tree. He's also done some work on using low-rank reconstruction to take advantage of the spatiotemporal correlations in the data. And you can see that does quite a nice job of denoising and allowing you to see vascular features that are invisible using a conventional reconstruction approach. And then more recently still, Chijia Shen in the group has been working on a cones acquisition method. So this is the same type of approach, using a golden angle acquisition using spokes. But what you can see is that whereas with the spoke acquisition, we have quite significant gaps in K-space at its outer edges, which means that the spatial information is quite limited. With the cones trajectory, you have a much more uniform acquisition in K-space, and that leads to higher resolution angiographic and perfusion images, as you can see on this bottom row here. The most recent work that Tom's been doing is to add an inversion pulse just between at the end of the labeling and before the readout. This inverts the static tissue signal, and then you can sample the inversion recovery delay. And using that method, you can get, as well as the angiographic information and the perfusion information, you can also get structural images acquired with different degrees of T1 inversion recovery weighting. So I'm just going to change gears now and tell you about some of the work we've been doing recently on measuring arterial stiffness. So this is defined as the ability of the vessel wall to distend in response to the cardiac pulse wave moving through the vascular tree. And increased stiffness has been shown to lead to increased transmission of pulsatility through the vascular system, which can lead to microvascular damage. It's also closely related with atherosclerosis and vascular disease, which can be difficult to detect in its early stages. And so we're hoping that arterial stiffness measurements can give us the potential of detecting some of these diseases at an earlier time stage. And one of the ways that you can do that is using pulse wave velocity. So this is just measuring the cardiac velocity waveform at two different locations in the vascular tree, measuring the time difference between them and the path length, and then working out a velocity from that. Now, in the case of vascular stiffness, the pulse wave velocity increases, so the pulse wave moves through the vascular tree in a faster way. There's not a particularly standard way of measuring things, but one of the ways that is measured is a carotid femoral pulse wave velocity. So this is measuring waveforms at the location of the carotid artery and the femoral artery. And then in the simplest case, you just take the linear distance between them to get you a pulse wave velocity with a correction factor in, which is a standard correction factor. However, this is only giving you systemic pulse wave velocity. It's not telling you anything about the local vascular stiffness. And so we've been trying to work on methods that will give us information on local pulse wave velocity and local vessel stiffness. For example, looking in the carotid arteries, and using time of flight angiography, we can measure the actual distance traveled and not have to rely on linear distances as well. So we've been working on a standard phase contrast angiography approach. We've added multiband excitation, and you can see here an example of the sequence. So the velocity encoding gradients are shown here in dotted lines, and that induces a phase shift into the moving spins. We've combined that with multiband excitation and grappa reconstruction, which allows us to get this data quickly in a single session and then separate the slices and be able to measure time difference between them. So this is Yang Ji at the top, who developed the sequence, and then Ben Keedwell has been using it more recently. I'm going to show you some of his results in the next few slides. Oh, and this has completely failed. This is meant to show you some different, yeah, that's not going to work. So apologies, this slide has failed. Ben has been using 3 different measures of detecting the pulse wave inflection. Firstly, just using an intersection of tangents, where you fit a tangent to the baseline and a tangent to the upstroke, and then the intersection of those is the pulse arrival time. And he's used 2 other methods, which are based on sigmoidal fits to the pulse wave velocity profiles. And in one case, fitted the maximum of the first derivative, which occurs approximately halfway up the upstroke. And in the second approach, he's used a maximum second derivative, which occurs closer to the inflection point of the pulse wave. So this is an experiment where we wanted to just compare these different methods, these analysis methods, and also we tested the hypothesis that we had that if we use simultaneous multi-slice, that we would actually get more reproducibility than if we use consecutive single-slice acquisitions. So this is just, in this case, 2 slices. And what you can see in these graphs is, firstly, that interestingly and unexpectedly, the simplest method of tangent intersection seems to have the lowest shot-to-shot reproducibility, so the best reproducibility, with the other methods giving worse performance. So this is left internal carotid artery, right vertebral artery, and the different color bars here are the different techniques, the different analysis techniques. Also, what we found was that the multiband acquisition didn't seem to improve the reproducibility over the single slice acquisition. Clearly improves the temporal efficiency of the experiment, but it doesn't seem to increase the physiological noise that we were finding. So we wanted to try and understand this, and we came up with a couple of sequences to try and help us understand this. So this is a version of the sequence where we're just collecting a profile at very high temporal resolution. So we have a single reference scan at the beginning, followed by these velocity encoded scans. So following a single R wave, we're collecting a series of about 100 velocity profiles, and then we're repeating that 246 times. So we've got 246 heartbeats where we can look at the shot-to-shot reproducibility of our measurement. This is another failed slide. This is not going to be very helpful because you can't see any real data here. But so this is a single profile acquired. Yeah, it's really hard to explain this without the other bits of data. I'm going to just move on and show you a blank slide. Yeah, this is absolutely hopeless. These slides have been thoroughly corrupted, I'm afraid. I can't show you any data. What you would have seen here is an agreement, or at least an observation that we made, that the temporal, so we were able to fit the arterial arrival time at each slice. And what we were seeing was that we were getting modulation, which was at the same frequency as respiration. And when we analyzed the frequency of that, which you can't see either, we found that the frequency was identical. So we confirmed that the fluctuations that we were seeing in the pulse arrival time were in exact alignment with the fluctuations that we were seeing in the respiration cycle. This is another experiment where we were looking at a faster temporal resolution. So we cut the spatial resolution down to 0.9 millimeters by 3.4 millimeters. We were able to get an image every minute, and then we ran 20 repeats. So over a 20-minute period, we could look at the variation in our ability to measure pulse arrival time and pulse wave velocity. This time with the multiband sequence, this is 5 slices, and I guess I'm not going to be able to show you any results from that either. We used the vascular modeling toolkit within 3D Slicer to get the actual distances involved, and I'm afraid you can't see any data here, or indeed here. This is really are very annoying. So what I was hoping to show you here was that we were getting some very nice measurements. Firstly, we were seeing very slow fluctuations in addition to those fast fluctuations associated with the respiratory cycle. We were getting very slow fluctuations in the pulse arrival times, which we think are caused by slow fluctuations in blood pressure, so we're going to test that next. However, what we were also seeing was a fairly constant pulse wave velocity. And when we measured as a function of age in a series of volunteers, we got a very nice monotonic curve, which I wish I could show you, and I can show anybody who's interested the slides later. But we saw a very nice monotonic increase in pulse wave velocity with age, which leads us to believe that we've got good sensitivity and that we will be able to see pathological changes in patients. So I'm very sorry that you couldn't see any of that data, but I will just end by summarizing that I hoped to have shown you that MRI offered a very rich palette of methods for assessing cerebrovascular health, as well as angiographic depiction. You can do quantitative perfusion imaging. You can combine it with angiographic subtraction angiography as well. Vessel wall pathology, allowing you to look at plaque, vessel wall plaque, and characterizing that in a quantitative way, and various physiological measures of cerebrovascular health, such as oxygen extraction fraction, which I didn't have time to show you today, and pulse wave velocity to assess vascular stiffness as well. So I'm sorry about the lack of data, but thank you for your attention.
Thank you very much, Professor JEZZARD. Please remain on stage. We'd like to invite Professor Chen Eugene to present a souvenir to you as a token of appreciation.